Imagine a medical diagnosis where the name itself is essentially just a total historical accident.
Right.
Like where the symptoms have been deeply misjudged and even, weaponized against patients for decades.
Yeah, absolutely.
And where the person who finally invented the gold standard cure built it while, well, secretly locked in a psychiatric ward, battling the exact same condition herself.
It's a wild story.
It really is. Welcome to the Deep Dive. Today, we are taking a stack of clinical history, psychological theories, and modern diagnostic manuals to unpack a heavily stigmatized condition, borderline personality disorder, or BPD. So if for everyone listening, we're glad you're here with us. Okay, let's unpack this. Because usually when you talk about a medical diagnosis, you expect precision, right? You break an arm, the x-ray shows a jagged line, and that's that.
Yeah, it's clear cut.
Right.
Right.
But when you step into this landscape of intense, really unstable emotions, that x-ray machine feels like it's totally broken.
That is the perfect analogy to start with, actually, because what we want to do for you today is really clear away all the folklore, all that historical baggage, and look squarely at the intense, highly unstable emotions that sit at the absolute core of BPD.
Right.
To understand this condition, you really have to look past the label itself.
So let's start there, because before we get into the wild history of how this condition was even named or, how it's treated, we need to understand what it actually looks like. Like, what is happening inside someone who receives this diagnosis?
Well, in the current American medical framework, the DSM-5 BPD is grouped into what's called cluster B.
Yeah.
And that's the category for personality disorders characterized as dramatic, emotional, or erratic.
Got it.
But instead of just, reading down a clinical checklist of the 9 criteria, it's much more helpful to understand that BPD essentially attacks a person in 3 core areas: their emotions, their relationships, and their sense of self.
Okay, let's break those down. Starting with the emotions, what does that volatility actually feel like for the person?
It is a profound, affective instability. I mean, imagine your emotional baseline is just a raw nerve.
Oh, wow.
Yeah, the highs are totally euphoric, but the lows are a crushing, persistent emptiness. And the shifts, they happen incredibly fast.
How fast are we talking?
Well, someone with BPD might experience intense, inappropriate anger or overwhelming despair. But unlike, say, a long-term depressive episode, these moods might only last for a few hours.
Really? Just hours?
Yeah, hours or maybe a day before swinging entirely back.
So if your internal emotional weather is shifting that violently, I have to imagine that creates absolute chaos in your relationships.
It creates a hurricane. The relationship criteria for BPD involve a pattern of highly unstable, intense connections. There are these really frantic efforts to avoid abandonment.
Even if the abandonment isn't real.
Exactly, whether that abandonment is real or just perceived. And a hallmark of this is a psychological defense mechanism called splitting.
Right, splitting. I've heard that term used a lot casually. That's when the brain can't hold contradictory thoughts at the same time.
Right. Yes, it's an inability to integrate the good and the bad. So people or even situations get categorized in absolute extremes.
Like all good or all bad.
Exactly. A partner might be idealized as the perfect savior in the morning, but if they are, say, 5 minutes late for dinner, the BPD brain might split and suddenly devalue that same partner as entirely malicious and uncaring.
So there's just no gray area at all.
None. There is no gray area in that moment.
Okay, so you have this emotional hurricane, you have relationships swinging from all good to all bad. What about the third area you mentioned, the sense of self?
Well, when your emotions and your relationships are that volatile, it becomes nearly impossible to anchor your own identity.
That makes sense.
Yeah, you see a markedly unstable self-image. And when the internal pain of all this becomes unbearable, it often leads to severe impulsivity, reckless driving, substance abuse, and tragically, recurrent suicidal behavior or severe self-harm.
Which I assume is usually what gets the medical attention.
Right. That is often the crisis point that finally brings someone into a clinical setting.
Looking at that picture, the emotional instability, the splitting, the frantic fear of abandonment, it is devastating. But what is glaringly absent from everything you just described is any sort of border.
Right.
So why on earth is it called borderline personality disorder? What borderline are we even talking about?
Well, we're talking about a borderline that doesn't even exist in modern psychiatry anymore.
Wait, seriously?
Seriously. To understand the name, you have to go all the way back to 1938.
Okay.
An American psychoanalyst named Adolf Stern was treating a group of outpatients who were just baffling him. They weren't responding to standard Freudian psychoanalysis.
Why not?
They were deemed too fragile for the methods used on neurotic patients, but they clearly weren't hallucinating or entirely detached from reality, so they weren't psychotic either.
Ah.
So Stern literally described them as a borderline group sitting right on the boundary between neurosis and psychosis.
So we are basically using a 1938 map to navigate a modern city.
Yes. And different cartographers just kept adding to that same flawed map. In the 1960s, Otto Kernberg brought in the psychoanalytic theory about splitting that we just discussed, giving the concept a bit more structure.
Right.
Then, in 1980, psychiatrist John Gunderson wanted to legitimize the diagnosis. He developed a structured interview to prove these patients could be reliably identified.
Which is what pushed it into the diagnostic manual.
Exactly. That pushed BPD into the DSM-3 as an official checklist diagnosis.
It's like a bizarre geological formation. You have a 1938 observation of hard-to-treat patients, layered with 1960s psychoanalysis, topped with a 1980s checklist.
That's a really good way to put it.
And the entire medical community just agrees the name is an artifact, yet it has stuck around for nearly a century.
Yep, it's stuck.
But having this checklist of symptoms doesn't explain what's actually happening inside the person's head.
Yeah.
Like, what is misfiring to cause this level of pain?
And that was the missing piece for a very, very long time. Historically, the prevailing wisdom was incredibly judgmental. Oh, yeah. Clinicians just viewed these patients as inherently difficult. But that completely shifted thanks to Marsha Linehan and her biosocial theory.
Okay.
It is the leading explanatory framework today, and it completely reframes BPD.
So how does the biosocial theory explain it? What's the mechanism?
It proposes that B to C is the result of a perfect storm. It's a collision between biology and environment.
Okay, the bio and the social.
Right. The first ingredient is a biological emotional vulnerability. Some people are simply born with a nervous system that has a hair trigger alarm.
So it just goes off faster.
It reacts faster to emotional stimuli, the reaction is far more intense, and it takes significantly longer for their nervous system to return to a baseline state of calm.
So the biological hardware is just running hot.
Exactly.
But biology isn't destiny, which I assume is where the social part of biosocial theory comes in.
Exactly right. That biological sensitivity collides with what Linehan termed the invalidating environment.
Invalidating environment, what does that look like?
This is a caregiving context that consistently punishes, trivializes, or dismisses the child's emotional experiences.
Oh, okay.
So a highly sensitive child is genuinely devastated over something, and the environment responds with, stop being so dramatic, you're fine.
Wait, hold on. When you use the phrase invalidating environment, that immediately sounds to me like we're just blaming the parents. Are we saying BPD is simply caused by abusive parenting?
That is a vital distinction to make, and it's a very common misunderstanding. No, invalidating does not automatically mean abusive.
Okay, good to clarify.
A caregiver can be incredibly loving, well-intentioned, and supportive, but simply have a completely different emotional temperament.
Like they just don't get it.
Exactly. If a very stoic, practical parent is raising a child with a hair-trigger emotional system, that mismatch alone can be profoundly invalidating for the child.
Interesting.
The environment just fails to teach the child how to label and regulate those massive feelings.
That makes a lot of sense. It's like being born with a microphone that picks up every tiny sound, but your family is constantly telling you to stop covering your ears because it's not that loud.
Oh, I love that.
It doesn't mean they're evil, they just don't have the same microphone.
That's a great way to look at it. However, we do have to acknowledge the clinical reality here too.
Which is?
While invalidation isn't always abuse, studies consistently link BPD to very high rates of severe childhood adversity. A majority of people diagnosed with BPD in clinical settings do report histories of abuse, neglect, or early separation.
Wow. Okay, so if you put a biologically sensitive kid in an environment that constantly tells them their reality is wrong, that sounds like a recipe for a massive escalating collision.
Yeah.
Does one trigger the other?
Yeah, that collision is the third principle of the theory, the transaction.
This transaction.
It's a vicious cycle. The child doesn't learn healthy coping skills, so their distress escalates into extreme behaviors just to get noticed.
Because that's the only way people listen.
Exactly. But then the environment responds to those extreme behaviors by becoming even more dismissive or punitive.
Which just makes the kid panic more.
Right. The child's emotions escalate further, the environment pulls further away. It's an agonizing spiral.
And Marsha Linehan understood that spiral better than literally anyone because she didn't just study it in a psychology lab. Here's where the story gets truly incredible.
That really does.
We know Marsha Linehan is the creator of Dialectical Behavior Therapy, or DBT. She published a landmark study in 1991 proving that DBT basically halved the rates of self-harm in these patients.
It became the undisputed gold standard.
Right. But she kept her own history completely private for decades until a bombshell interview with the New York Times in 2011.
It remains one of the most profoundly moving moments in modern psychiatric history, I think.
As a teenager and a young woman, Linehan was hospitalized for over 2 years at the Institute of Living in Connecticut. She experienced severe self-harm, chronic suicidality, and was locked in seclusion rooms. She was dealing with what today would absolutely be diagnosed as severe BPD.
Yeah.
She literally built the most effective clinical manual for this condition from the inside out.
What's fascinating here is how her personal survival inherently shaped the architecture of DBT.
How so?
Well, the therapy is built on a dialectic, which just means balancing two seemingly opposing truths. In DBT, the therapist must provide radical acceptance of the patient's immense suffering while simultaneously executing a relentless push for change and skill building.
Because she knew both were necessary.
Exactly. She knew that if you only push for change, the patient feels invalidated. But if you only offer acceptance, the patient stays stuck in agony.
But if Linehan's theory shows that the environment, and very often a traumatic environment, as you pointed out,
Right.
is a primary driver in this transaction, it naturally begs a massive question.
Yeah.
If someone is reacting to severe adversity or abuse, why are we calling it a personality disorder at all? Like, is BPD actually just a trauma response?
You have just hit on debate number one in the psychiatric field right now.
Really?
Yes. In the 1990s, a psychiatrist named Judith Herman, who actually pioneered the concept of complex PTSD, argued exactly this point.
What did she say?
She suggested that labeling these severe trauma-driven symptoms as a defect of personality implies a permanent characterological flaw.
Which is super stigmatizing.
Deeply stigmatizing. She argued that we are taking trauma endures and mislabeling them as personality defects.
And the major diagnostic institutions are actually grappling with this right now, aren't they?
Very much so. The World Health Organization's manual, the ICD-11, which went into effect in 2022, formally added complex PTSD as a distinct diagnosis.
Okay. Yeah.
And clinicians debate the overlap daily. Both CPTSD and BPD feature severe emotional dysregulation and unstable relationships.
So how do they tell them apart? Or are they literally just two words for the same thing?
They are distinct, though they often co-occur. CPTSD requires a clear, prolonged trauma history, and it really centers on a persistent sense of threat and a negative self-concept.
And BPD?
BPD, on the other hand, involves those frantic efforts to avoid abandonment, the rapidly shifting self-image, and the intense splitting in relationships, features that aren't inherently required for CPTSD.
Okay, I see the difference. But the debates over how to classify this don't stop with trauma, do they? The actual architecture of how we diagnose personality is literally being dismantled right now.
It is a massive shift. The ICD-11 didn't just add CPTSD, it scrapped the old categories of personality disorders entirely.
Wait, scrap them entirely?
Entirely. Instead of saying you have BPD or you have narcissistic personality disorder, the manual now uses a dimensional model.
What does that mean?
It diagnoses a general personality disorder rated by severity from mild to severe, and then adds trait qualifiers, like a borderline pattern.
Here's where it gets really interesting. Sounds like psychiatry is debating whether BPD is a specific species of animal or if it's just a descriptive word for how loudly any animal roars.
That is a brilliant analogy, yes.
Right, like is it a category or a spectrum?
Exactly. Are we dealing with discrete, separate diseases that you either catch or you don't? Or is personality functioning a continuous spectrum that every single human being falls somewhere on? And this diagnosis just represents the severe, impairing end of emotional ability and impulsivity.
And the U.S. is looking at this too.
Yeah, the American manual, the DSM-5, is exploring this exact same dimensional approach in its alternative model section.
This debate over labels is so vital because when you look at the history, the borderline label has been heavily weaponized. And it seems to disproportionately target women.
We absolutely have to talk about the gender bias here. If you look at clinical samples, meaning people who are actively in treatment or hospitalized, roughly 75% of those diagnosed with BPD are women.
3/4. So is there a biological reason women are more susceptible?
No, and that's the catch. When researchers do community studies, meaning they sample the general population, regardless of who is seeking treatment, they find the prevalence of BPD is essentially a 50-50 split between men and women.
That is a huge discrepancy. What is causing that massive mismatch?
Diagnostic bias.
Just bias.
Pretty much. Historically, clinicians have been much more prone to apply the borderline label to a woman exhibiting erratic, impulsive, or angry behaviors.
And what happens to the men?
Well, when a man walks into a clinic with the exact same emotional dysregulation and impulsivity, he is far more likely to be diagnosed with antisocial personality disorder or a substance use disorder.
Wow.
The clinician's own implicit biases actively shape the label.
Which brings us to perhaps the most toxic label of all, the M word.
Oh, yes.
Manipulative. For the longest time, BPD patients were just written off by hospital staff as manipulative or just seeking attention.
And this is where we see a profound paradigm shift in modern psychiatry. Historically, viewing a patient's self-harm or suicidal crisis as an intentional, calculated bid for control was catastrophic.
I can imagine.
It justified colder, punitive treatment from clinicians at the exact moment the patient's nervous system was in total collapse.
But modern specialists view the word manipulative as a giant red flag for the clinician,
Right.
not the patient. Right.
Absolutely. Treatments like DBT or mentalization-based treatment or good psychiatric management, they all agree that these crises are not calculated tactics to control others.
What are they then?
They are desperate communications from an overwhelmed nervous system that lacks the skills to manage emotional pain. If a patient is self-harming, it's not manipulation. It's a profound skills deficit.
And you don't punish someone for not knowing how to do something.
Exactly. You don't punish a lack of skills, you teach the skills.
Let's clear up a few other modern myths while we're at it, because popular culture gets this so wrong. First, BPD is not just moodiness or having a dramatic personality. It requires severe functional impairment across multiple domains of your life.
Yes, it has to be deeply impairing.
And second, it is frequently confused with bipolar disorder. How do you explain the difference?
The key distinction really comes down to time and triggers.
Time and triggers. Okay.
BPD mood swings are highly reactive to immediate interpersonal triggers. If someone perceives a rejection, their mood crashes instantly, and that despair might last for a few hours or a day.
And bipolar.
Bipolar disorder involves mood episodes, like mania or deep depression, that last for days or weeks at a time. And they arise much more independently of what's happening in the room that exact minute.
That's a really clear distinction. And third, just to be very clear for everyone, there is no FDA-approved magic pill for BPD.
None.
So medication doesn't fix it.
A psychiatrist might prescribe a medication off-label, like a mood stabilizer or an antipsychotic, to help take the edge off a specific symptom during a crisis, but you cannot medicate away a personality structure or a skills deficit.
Right.
Structured psychotherapy is the only primary evidence-based treatment we have.
Okay, so if there's no pill, and it's deeply ingrained in your emotional reactions, that brings us to the ultimate misconception, the one that used to make this diagnosis feel like a life sentence, the idea that BPD is a hopeless, permanent condition.
For a long time, clinical folklore said exactly that. Once a borderline, always a borderline.
But that's not true.
The science proved the folklore entirely wrong. And this brings us to the McLean study of adult development. It was led by researcher Mary Zannarini at a Harvard-affiliated psychiatric hospital.
And they tracked patients over a long period of time to see what actually happened to them.
Yes, it was an incredibly rigorous longitudinal study. They followed hospitalized BPD patients for over a decade, and the findings were counterintuitive to everything psychiatry believed at the time.
What did they find?
They found exceptionally high rates of symptom remission. A large majority of patients no longer met the diagnostic criteria for BPD within about a decade of follow-up.
Wait, really? Without a magical cure, how does the condition just go away?
Through therapy, brain maturation, and life experience, patients eventually build enough emotional regulation skills that their symptoms subside below the diagnostic threshold.
So they just learn how to manage the storms.
Exactly. Now, full functional recovery, like holding down a steady career or maintaining long-term healthy relationships, can lag behind the symptom remission.
Yeah.
But the intense, acute crisis phase, it is absolutely not permanent. BPD actually has one of the more favorable long-term symptomatic courses among all personality disorders.
That is so hopeful. You know, McLean Hospital is famous for another reason in the BPD world, too.
Yeah.
Susanna Kazin spent 18 months there in the late 1960s, and her memoir, Girl, Interrupted, which obviously became the famous 1999 movie, is basically the cultural touchstone for BPD.
It really is.
It captures that era's skepticism perfectly. Like, was the diagnosis real, or was psychiatry just pathologizing non-conforming, difficult young women?
And that cultural footprint has only grown because BPD has a massive impact on our broader society. Even though it's estimated to affect only 1 to 2% of the general population, it accounts for up to 20% of psychiatric inpatients.
That is a massive disproportion.
It disproportionately impacts the entire crisis mental health system.
And the vocabulary has leaked out of the clinic and into our everyday lives. You hear people in the workplace talking about someone splitting on them or dealing with an invalidating environment.
Which is a real double-edged sword, honestly.
Oh, so?
Well, on social media platforms right now, especially TikTok, there is a massive surge in BPD self-diagnosis content. Millions of views on videos explaining the symptoms.
I can see why mental health professionals are torn about that. On one hand, it's amazing for destigmatizing this deeply painful condition. If you are suffering, finding a community that makes you feel seen is incredibly powerful.
Absolutely.
But on the other hand, you have this checklist-style self-labeling that totally ignores this severe, disabling functional impairment you need for a real diagnosis. If you're scrolling through social media right now, it really makes you wonder where we draw the line.
It does.
Like, how do we balance validating someone's real pain without pathologizing normal human emotions and breakups?
It is a very fine line to walk. But if there is a primary takeaway from all the sources we've looked at today for this deep dive, it is the profound paradigm shift we've undergone as a society. We have moved from a punitive, judgmental stance, viewing these individuals as manipulative and untreatable, to a stance of radical compassion and skill building.
You really have. Just think about the journey we've taken today. We started with BPD as this vague 1938 psychoanalytic bucket for patients who were too fragile for standard therapy.
Right.
And we've watched it evolve into a highly specific, compassionately treated disorder of emotion regulation.
The emotions at the core of BPD are intensely painful. But the prognosis, thanks to the therapies we have now, and thanks to pioneers like Marsha Linehan, who literally fought her way out of the darkness to build a ladder for everyone else, it is incredibly hopeful.
It's an amazing evolution.
Yeah.
But, you know, considering all those structural changes we discussed with the ICD-11 and the DSM-5, it leaves me with one really big question about the future.
It's the question the entire field is asking right now.
What's that?
If modern diagnostic manuals are moving away from discrete categories entirely, if they're moving toward a dimensional spectrum where everyone has a personality profile of varying severity,
Right.
will the very label of borderline personality disorder eventually disappear from our medical vocabulary entirely, leaving only the treatments behind?
Wow. That is something to chew on.
Yeah.
The X-ray machine of the mind might just be getting a software update that deletes the old borders altogether.
Exactly.
Thank you so much for joining us on this deep dive, for exploring the profound complexities of the human mind, and for looking past the labels with us. We'll see you next time.